Hi, everyone. I'm Cynthia Charles, Vice President of Communications and Public Relations for the North Carolina Healthcare Association. I'm pleased to welcome you to our It Takes a Conversation virtual town hall. This is part of a series of town halls that the association is hosting to connect health system and hospital leaders with patients and employers and other stakeholders in the communities that we serve. Our first virtual town hall in September brought together hundreds of people for a great conversation, and I know that you'll enjoy today's conversation as well. All lines will be muted throughout the program. If you have any technical issues during the webinar, please send a note in the question to the organizer, James Hayes. Questions may be asked anytime during the program by typing your question into the question pane that's located in your control panel. Many of you have submitted questions in advance, and we have looked at those and categorized them and chosen a number of them that the moderator will be asking the speakers today. And now I'll introduce you to our moderator for this virtual town hall, Jim Longworth. Jim is an award-winning broadcaster and columnist, and he is the host of a long-running public affairs program in the Triad called Triad Today. Jim, welcome, and let's go with our program. We have a wonderful lineup today. Thanks everyone so much for participating.
Thanks, Cynthia, and thank you, everyone. I'm really honored to be here today for this important conversation. Before we get going, let me remind you of a few things. Today's town hall, as Cynthia mentioned, is brought to you by the North Carolina Healthcare Association. NCHA is an advocacy organization that works with its 130 member hospitals and health systems to improve the health of North Carolinians and the communities in which they live. It does this by advocating for sound public policies and collaborative partnerships so that high quality health care can be made more equitable and accessible for everyone in our state. Now, as Cynthia mentioned, these virtual town halls are designed to build relationships between North Carolina residents and the hospitals and health systems that serve them. Toward that end, we hope you have sent us your questions when you first registered, and if not, as Cynthia said, you can do so now through going to the appropriate process on paying. We also invite you to visit nchealthcare.org to learn more about what North Carolina health systems and hospitals are doing specifically to respond to the coronavirus and to improve the health of everyone in our state. But we will, of course, get to that topic throughout this discussion. Please keep in mind that the information being shared by our panelists during this virtual town hall should not be taken as medical advice. And now let's introduce our panelists for today's town hall. Steve Burriss is president of UNC Health Triangle Region, and Dr. Chris DeRienzo is chief medical officer of WakeMed and Hospitals, and Katie Galbraith is president of Duke Regional Hospital. And we welcome all three of you folks. Thanks for doing this.
Happy to be here, Jim.
Thanks for having us.
I'm not going to call on anybody specifically, so just jump in as you want to, but I'd like to get a response from each of you to these main topics. And the first one, every major health organization, as you know, has warned us that we're headed for a surge in COVID-19 cases over the next few months. So here's the first question. How can people stay safe in general? Is it okay to vote next week? Should they travel or attend family gatherings with the holidays coming up? What are your thoughts? Who wants to take that first?
Jim, I'm happy to jump in. Our numbers are increasing across the UNC Health system. We see them increasing across the state and the country. I think recently we had a test day where there were 80,000 new cases in a single day. Late September, our census had dipped to only about 94 patients across the healthcare system, but in the last 30 days, it's risen nearly 70% to 158 inpatients in our system. So yeah, I'm glad you said this is not medical advice. I'm not an epidemiologist, so but how can we stay safe? You know, I'm pretty certain that a surge in interstate travel and family gatherings over the next couple months are not going to help bring this disease back in check to the numbers we were seeing months ago. But I'm also mindful that many of us haven't seen family members in a long time. We have a 24-year-old son who lives in San Francisco and haven't seen him since January. And I would really like the opportunity to see him over the holidays. So I think it becomes a personal choice about the risks involved. Certainly there are cases of COVID everywhere across the country. And so there's probably no really particularly safe place to be, but the safest thing would be to stay home and gather with those that are in your household. But if you don't stay home, maybe travel by car is a good option. Limit the number of people you interact with and the duration and those sorts of things. And of course, the 3 W's. You mentioned voting. I voted by mail. I think it was a great option this year. Those are kind of my thoughts on what we can do to stay safe.
All right, Katie or Chris?
Sure, I'll jump in. So certainly everything that Steve outlined, and I'll start also by saying I am not a clinician, so certainly no medical advice here. But in talking with our experts, we do expect that we're going to continue to see cases rise, and we all, I think, have the opportunity to just reinforce and be champions for the 3 W's. Wearing our masks consistently, waiting 6 feet apart, so the social distancing, and washing our hands. And I think we can't reinforce that enough. Certainly, I certainly hope that everyone will go out and exercise their right to vote next week. And a reminder that the deadline for absentee ballot requests is, I believe, 5 p.m. today. So get that request in if you want to vote that way.
And everybody just take your ballot to Chris's house. No, I don't know why I said that.
But you know, you can safely vote, but make sure that you are standing 6 feet apart, that you're waiting with your mask on, that you're washing your hands. Bring sanitizer with you with at least 60% alcohol in it. And the same with the holidays. I mean, I think the holidays are going to be tricky because we've been at this now for 8 months. People are exhausted. They're tired of the restrictions, want to see their families, and that's completely understandable. But we also want to protect our families. We want to protect our friends and our neighbors. And so making those sacrifices to just maybe get creative this year. Maybe it's that at Thanksgiving, instead of everyone meeting up at grandma's house, it's everyone makes, shares recipes and makes the same meal, but they join by Zoom or virtually. There are some creative ways that we can go about this that will keep us safe. And still allow for some of that socially distanced interaction.
Chris, give us the medical side of this.
Sure. I think even though I'm a physician, Steve and Katie really hit it on the head. Right? We, in my family, we sort of make assessments on where we feel comfortable going based on how well that place is adhering to all of the things that we know reduce the risk of transmitting COVID. So my wife and I, we both went to early vote at a Wake County site, and it was perfectly laid out to adhere to the 6-foot guidelines. There was ample utilization of masks as you walked through the interior of the building, which was very well spread out with good ventilation. We could walk through, complete our voting, submit, and head right out. And so whether it's visiting with family, whether it's going to restaurants in the community, I think it's incumbent upon us to make sure that the places we choose to go are places that are respecting this virus and the things that we know will reduce transmission. There was a great article over the weekend in newspaper around pandemic fatigue, and that's real. And I think, as Steve and Katie noted, I feel that, and I think we all sense that. And we know that as soon as we begin to let our guard down, this virus reminds us about just how powerful it is.
And it is real. I know the politicians are trying to make it political, but it is real, right, Chris?
That's exactly right. Steve, spoke to it. Katie's spoken to it. I speak to it. There's not a day goes by across the health system here at WakeMed or at Duke or UNC or anywhere in the state where we're not caring for patients who are incredibly, incredibly sick. That's not to say every patient is incredibly sick, but without question, this is a real virus, and we've seen it across our nation.
let me get each of you to comment on something that sort of piggybacks on this, and that is what precautions. Give me an example of precaution that your hospitals have taken to protect staff and patients.
I'm happy to start on that one. We have had very proscriptive guidelines in place now for months, as hospitals have around the state and around the country, relative to restricting the number of folks in our building. We wish we were at a place where we could welcome all kinds of visitors back at all times of day in all settings, but we know that we can't do that right now. So the visitors we do allow into our buildings go through a rigorous screening process, including temperature screening. We limit movement throughout our buildings. Within our buildings, everyone is wearing masks. For patients who can't wear masks, we have face shields for our clinicians. And so there's a series of best practices that have really been proven to reduce in-building transmission that have been in place here at WakeMed and at many healthcare facilities now for months and months and months.
Katie or Steve?
Yeah, I would say I think we're following very similar precautions at all three health systems, and we coordinate together too as well. I mean, we're talking together on a regular basis to see what we can learn from each other, and best practices that we can institute. But certainly the screening, the universal masking, we all went to that very early on in this. So very similar precautions that we're taking.
Steve?
Yeah, I would agree. I mean, we're pre-testing all of our surgical and procedural patients and all of our inpatients to make sure, we understand that who's a positive patient and who's not. One of the things we did very early on, and I didn't so much view it as a precaution, but it's become one of the best precautions that we've had so far, is the opening of these respiratory diagnostic centers. And they've proven to be a very good way of keeping potentially positive patients out of the hospital environment while they're going through the testing phase. And almost it really started as an effort to sort of coordinate our testing, but it ended up also being a great way to save on PPE. It's a much more efficient use of that equipment because these facilities are outdoors, and it's just a much more elegant and efficient way of doing this. We of course have very rigorous cleaning and those sorts of things in place. But I think one of the precautions that we could have been better about early on, and we just didn't understand how long this disease would go on at the time, is to make sure that we're taking care of our coworkers. And this has gone on for a long time, and we thought there was some light at the end of the tunnel as the numbers started to go down, but the numbers are now creeping back up, and I think they're going to peak at a level higher than the previous peak in the coming couple of months. And these folks go in and they risk their health, their own personal health and their family's health every day by taking care of patients. And it's taken an enormous emotional toll on them. And, I think early on we were doing a lot to support them, and, we had parades for healthcare heroes, and all sorts of free things were coming in for them. But as this has gone on, those things have kind of tailed off, and that's understandable. But the toll this takes, continues every day on our coworkers. And so our psychiatry department's done a wonderful job of providing resources and options for our coworkers. And, I think that really needs to be a big focus of ours going forward.
I don't know if everybody wants to jump in on this or not, or Chris, if you just want to handle it, but I'm curious. We get conflicting information about when a COVID vaccine will be available, if and when it would be available. Nobody knows. So in the interim, are you guys advising the staff to advise patients, to advise families to go ahead and get flu shots and go through that whole routine, or what?
Jim, terrific question. Independent of a COVID vaccine, there has been no year more important to get a flu shot than this year. And I think my two co-panelists would agree that one of our biggest risks as we walk into flu season is our usual rise of hospitalizations around influenza layered on top of another rise in patients with COVID. And so the more we're able to reduce the burden of influenza this year compared to other years, the better we'll be able to handle whatever comes with COVID. Recognizing a vaccine for all Americans, is a long time off. And there's some evidence to suggest that there's hope on that influenza front. If you look at the experience in countries in the Southern Hemisphere, which you'll recall experiences their winter, 6 months offset from ours, country after country after country who are following the kinds of core public health recommendations around limiting COVID spread have had one of the lowest flu seasons in their recorded history. And so if we do the things that we know we need to do to prevent COVID and we get our flu shots, then there's very high hope that we can dramatically blunt the course of that curve over the next 4 months.
I don't want to interrupt anybody. Katie or Steve, do you want to jump in or you want to move on? Okay.
I think Chris said it beautifully.
Okay.
He did.
Completely.
Let's talk for a moment about health equity. What have you folks learned during the pandemic about reducing health disparities and improving equity? Steve, you want to start?
Sure, I'm happy to. There are a couple of positive things actually that have come about as a result of COVID. One is that the adoption of virtual care has really accelerated. But the second and more important one is that it's really shown a very bright light on the nation's health disparities. And so the system definitely has cracks, and there are certain populations, the Black, Latinx, and migrant workers have been hit particularly hard through this crisis. And one of our early strategies was to rapidly deploy a mobile testing unit to the underserved communities. And so we tapped into community leaders, agencies, grassroots organizations to help identify testing sites. And so we went to churches, we went to free health clinics, we went to public schools and charter schools in order to make sure that we were getting the vulnerable populations tested at a very high rate. We didn't advertise this, through the media or anything like that, but we did it through churches, grassroots organizations, community leaders, some web postings and things like that. By mid-September, I think we had almost 2,500 people who had been tested. 70% were from minority populations that were really experiencing a disproportionate impact of this disease. And a vast majority of these were also uninsured patients. And so the positivity rate we found around that population was much higher than what we were seeing in the general population. And so we were getting them to testing sooner than we could and intervening sooner. And I think that's really helped. But there's no doubt that this virus has had a disproportionate impact on certain populations, and we recognized that early on. All of us did. We've kind of talked about it in other forums.
Katie, talking about reducing health disparities and improving equity. What about at Duke?
Yeah, so absolutely. I mean, I think COVID has just really shined the light on the disparities that have long existed in the state and across the nation. And certainly we have worked, there are a number of different things that we're working on within Duke. We have not done mobile testing, but we have done targeted testing sites. And so we've worked with a testing site called the Holton Clinic in East Durham, and really focused on serving those who are traditionally underserved in our community. We also have both DCRI, so Duke Clinical Research Institute, with UNC, with the Center for Health Equity Research at UNC, have received an $80 million award from NIH that is really aimed at helping to understand, being the coordinating and data center for understanding over the next 4 years how to overcome barriers and increase testing specifically among underserved and vulnerable populations. So that's something that, again, we've done in partnership between Duke and UNC. There's also something called the Pandemic Response Network, which is again centered here at Duke, but working with broadly across the community and really aimed at helping to reduce those disparities. And that is symptom tracking, symptom monitoring, and follow-up for anyone who wants to sign up for that.
Chris?
I think Steve and Katie have spoken to that really nicely. The work that Steve mentioned, I saw was just published in New England Journal's Catalyst publication. It's a terrific piece. Yeah, I think from our perspective at WakeMed, we've been tremendously lucky to be able to partner with so many in the community around serving those who have been disproportionately impacted by this pandemic. There's not been homogeneity across the state in terms of who it's impacted economically, who it's impacting clinically, even geographically. There are some areas in the state right now that are hyper intense around COVID, and then there are others, that are less. But when I think about how, from the perspective here in Wake County, we've been able to, for example, really get in with our homeless population very early on and partnering with the county, with Oak City, with Dr. Klossner's work, putting folks up in hotels who did not have housing, who were super high risk very early on. That has saved lives. When I think about the Southeast Raleigh Masking Initiative, getting thousands upon thousands upon thousands of masks into our community early on, again, through very deep community partnerships, that wouldn't have happened. And that is getting to folks who otherwise would not have access to that kind of preventative equipment. And so to me, the light that's been shined, to use Katie's words there, I think has really lifted up lights inside so many in the community to serve those who really need our help.
I don't think it's an exaggeration to say that all eyes have been on the presidential election this year. There have been other races that people have been interested in, and regardless of your party affiliation, I think back, which shows my age, I think back to former Speaker of the House, Tip O'Neill, who said that all politics is local. And in that regard, it's really our state legislature here in North Carolina that has more of a direct impact on the health care of your patients and on the way your staff does their jobs. I think you would all agree that, right? Yeah. So if we agree on that point, my question to you would be, what one issue would you like to see state lawmakers address that would help hospitals better serve their communities?
I'm happy to jump in on that one, Jim. I think relative to hospitals, but more relevant to our state, all North Carolinians deserve access to affordable care. And we know that folks who have healthcare coverage have more access to preventative care and lead to better long-term clinical outcomes. And so whether it be Medicaid expansion, as other states have, or a North Carolina specific plan, I would love to see our state get together around some kind of expanding coverage for all North Carolinians to ensure access to affordable care.
Katie or Steve?
Yeah, I agree with that. I think Medicaid expansion or a program that's uniquely designed for North Carolina, but that expands access to care is the highest priority.
Yeah, I mean, I think those are great examples, and I also think it's not so much about one issue, but really sort of a unified effort to better serve our communities, to make sure that affordable, accessible healthcare is there for everyone. And our lawmakers have difficult jobs because they're responsible for these policies that affect so many people. But our real hope is that they prioritize affordable, accessible healthcare. And really the pandemic underscores the need that we've just got to work together on this.
And I think, I don't know, but I think we even have some of our state representatives who have signed on to this audience, and we appreciate them taking an interest in this. And certainly from the standpoint of the North Carolina Healthcare Association, although I'm not a spokesperson for them and they didn't pay me to say this, I think they do a great job in trying to pull these kind of efforts together to let the legislators know how they can help as well, and I appreciate that. Any of the three of you want to make a final thought or observation before we move on to audience questions? Okay, but let's do that. As I said earlier, a lot of you who, some 200 plus folks who registered for this virtual town hall submitted questions. And we tried to cull through some of these. We didn't have any method or madness to this. We just picked out some things sort of randomly. So let me go through as many of them as we can. Joshua Harris from Cary asked this question: what can the business community do to help support, well, the association itself, but also hospitals during the pandemic? What can the business community do to help? Who wants to take that?
So I'm happy to start on that one. I mean, I think, and I know I'm going to sound a little bit like a broken record here, but I think one of the biggest things that our business community can do is to continue to reinforce the importance of wearing masks, social distancing, hand washing, all of those public health practices that are essential. I think, you know, certainly there are other things that businesses can do. You know, paid time off for employees so that they can take sick time when they are sick so that they're not coming to work sick, I think is really important. And I know that can be challenging for particularly our small businesses. But we need people when they are sick to stay home and not be in the workplace. Those are the types of things that can have the greatest impact, I think, long term on this.
Steve or Chris?
I think Katie gave a perfect answer there. And the only thing I'd add to it, and I know she didn't mean to miss it, but it was flu shots.
Yes. Thank you.
Jim, the only thing I would add would be very early on, we saw such a tremendous outpouring of support from the business community, businesses completely redirecting their entire purpose, for example, from distilling liquor to providing hand sanitizer. And so just a thank you from all of us in healthcare to those in business for supporting us early on. And I think Katie and Steve hit in all the ways that we'd love to be able to continue supporting you.
This question's pretty interesting and pretty complex. Noshima Tab from Garner asks, can hospitals help facilitate collaboration between public health agencies and researchers in preparing for how a COVID vaccine might be developed and administered? Anybody want to start on that?
I'm happy to start briefly on that one, Jim. It's absolutely already happening. We've known that this effort to develop a vaccine was going to be the fastest in world history. And so for months and months and months, at a federal level, a state level, at a local health system level, we have been working together to ensure that we'll be here to serve the community. And that means, you know, applying early on through DHHS to serve as partner sites for the initial phases of vaccine, which are likely to be targeted at the kind of highest risk healthcare workers caring for populations. But then in the later stages, as we anticipate that to come, hopefully as quickly as folks can make it. And so I think it would be fair to say that this is the most collaboration that's ever been seen in the history of American healthcare among local systems and between the public and private communities.
Katie or Steve?
I think Chris said that very well.
I think Chris answered it well. The only thing I would add is the complexity of it is really incredible. Many of the vaccines that are coming out have to be stored at extremely low temperatures, like -70 degrees Celsius, and just not every doctor's office or community agency has a freezer that will keep vaccines that cold. And so the logistics of all this is very complicated.
I didn't mean to interrupt, but you made a great point there, because anybody that knows anything about, for example, shingles vaccinations, you go through the same thing. You go to some places and they'll some hospitals, doctors' offices, mainly doctors' offices, and they'll say, well, we can't administer the shingles vaccine, but you can go to the local pharmacy because John at the pharmacy has a freezer. And, you know, so we don't know how this is going to shake out. None of us knows what the vaccine is going to look like. Katie, do you or Steve have any anticipation about how a vaccine might be administered, sans freezer or not? I mean, do you have a strategy sort of in place to think about that? I know I'm putting you on the spot, but I'm just interested.
You know, I think we're all working through our strategies and our distribution plans and how we will manage that. I know we certainly are at Duke. I imagine Steve and Chris are as well. But we're also still learning on this. And so there are still there's still a lot of unknowns, I think. But we certainly are preparing and we're working on those plans and working with DHHS. And this really is a tremendous partnership and collaboration. And it will have to be moving forward.
I think that's right. When you look at just the distribution of kinds of vaccines, right? The negative 80-degree storage that Steve referenced, those are likely to be the mRNA vaccines, which are a totally novel kind of vaccine that's only been around for less than 10 years even. And then there are more typical vaccines that don't have to be stored that cold. We don't know exactly where we're going to get them from, if they'll come directly from manufacturers or if they'll be shipped through certain intermediaries, how it'll be distributed, how we'll figure out how much goes to where. And so it's fair to say that even in the presence of a lot of unknowns, systems like ours are working to make sure that whatever the final pathway is through which we'll be getting access to vaccine, we're doing everything we can to support getting that to the community as soon as it is safe and available.
Steve, I sort of cut you off before. I apologize. Did you want to wrap up on this?
No, I think Katie and Chris made the points I was going to finish with, so no problem.
So in a sense, though, the three of you are looking to, we've talked about partnerships. There could be some partnerships put in place once a vaccine or vaccines are ready, where everybody's sort of teaming up in the community to make sure there are points of administration, right?
That's correct.
Leoma Wilson from Raleigh asked this question. Do you believe there is an actual bias in the healthcare system when it comes to treatment of minorities, the disabled, and Medicaid recipients? I want to spend some time on this and get everybody's thoughts in depth if we could. Who wants to start on this?
I'm happy to jump in, or Katie, please feel free.
Yeah, so, I mean, I think absolutely there is bias. I think we all have bias, right? There's implicit bias and there's explicit bias, if you will. I think we have seen, and again, I do believe that COVID has highlighted disparities and inequities that have long existed. This isn't new with COVID. This is really the result of, and I tend to think of it as we almost have two pandemics simultaneously here, right? We have the COVID pandemic, and then there is the racism pandemic, and that is that we understand and recognize, and I think that has become crystallized more so, at least for me, and I think for us as an organization in the last several months, just what that racism truly is a public health crisis. And so do I believe that there is bias? Yes. Do I believe that there is intent with that? No, I think we are all, I can speak for Duke, we are working really hard to try to eliminate health inequities, but we have a long way to go.
I think Katie answered that beautifully. And I think we've all had periods of time, we've done targeted efforts over the years to deal with the disparities that we're aware of, but what we're in need of are really system-wide efforts to address these and to really understand the data and the science behind it. In July, UNC Health System hired its first system executive director, I hope I get this title right, for health equity, and her name is Dr. Crystal Sine, and she's really leading an effort to sort of evaluate, plan, implement science-based strategies to address the inequities and disparities that we see within the healthcare system. And she's off to a really fantastic start, and we're seeing data for the first time that is really helpful in addressing these things. So we have a really coordinated effort behind this now.
Chris?
Yeah, they've answered it well. The first step is acknowledging its presence and learning about it. We all have unconscious biases, whether they're intended or not, mean-spirited or not, they're there, and they're the series of filters through which we've learned to see the world. So we have to be aware that we're seeing the world through a filter before we can do something to change it. And I think Steve's point about data is right on. That once you can see the filters that are blocking your ability to clearly visualize the world, you've got to follow the data to tell you how do you, as systematically as they were put up, systematically take them down.
Look, I plead guilty to being an elderly white guy. So help me understand something here. Minorities are affected really more so per capita with COVID, for example, and there are other problems we've talked about. But when anybody of any race or religion comes into one of your hospitals and needs help, I'm trying to understand what somebody might mean by bias. I mean, how do you recognize bias? What form does it take? We didn't rehearse any of these questions, but I'm trying to understand. Help me understand. I mean, because everybody, I'm assuming, that works under you and for you is trying to do the best they possibly can, pandemic or not. So help me understand this.
Yeah, well, I think one thing to keep in mind is that when we think about health outcomes, only about 20% of that is really about the clinical care. So much of it is about the environment. And so it's about access to affordable housing. It's about access to transportation, food security, all of which is a product in many respects of years of an inequitable society. And so that has its impact in terms of health outcomes. In terms of bias, you know, again, it's implicit bias. We all have biases that are, as Chris explained, you know, sort of conditioned by our lifetime of experiences and what we see in the media, what we see all around us, that shape.
So can bias take the form of a health professional just not being aware of disparities that you've outlined?
Yes.
That's correct.
Yes.
Chris or Steve?
Understanding that bias and knowing that we have those biases, I think, is one of the first steps, right? So that now that I know that I have some biases, I can help keep myself in check.
Yeah, Jim, I think it goes even before, you know, walking into the hospital, right? There are folks who are reliant on their own vehicle for transportation. There are folks who are reliant on public transportation. There are folks who have to walk 3 miles just to get to public transportation. And so when we think about, you know, being late to a visit, it would be easy to anchor around, well, why didn't this person, you know, plan or do X? If your frame of mind is coming from, I get in my car and I drive to my doctor's office, you really have no idea what that person could have had to have gone through in order to construct a day that gets them to that place on time. And again, we only live, we only live kind of through our own experience. It's really, really difficult to put your head into what someone else's experience is. And I think that's what Katie's getting at, that you have to be proactive in doing that.
Yeah, and Steve, it's almost kind of like, not so much a racial thing, but years ago, there was a systematic implied bias about rural versus urban, so that a lot of people didn't have access to healthcare because there was no hospital near where they lived in a rural area. And then, of course, we had the growth of telemedicine to help out. So this really is something that we need to constantly work on, right?
Absolutely. I mean, it's shocking when you come to learn that from one zip code to another, the life expectancy can vary by 10 years. And it is these sort of structural things that have been in place for decades that really manifest themselves in these disparity numbers. And until you understand the data and what's causing those outcomes and differences, you know, it's hard to address the problems. But I do think as a society, certainly the last, you know, however many months have really created much more focus on these issues. I think there was already a growing focus on the things that lead to different outcomes in health, but this really crystallized it for the country. And I think all health systems are taking this more seriously than ever.
All right, Renee Bridges of Cary asked an interesting question. Renee says, what does the future look like for mental health services in the Triangle area?
So maybe I can share a little bit about our plans at Duke Regional, just because that's near and dear to my heart. But we have invested $100 million in expanding to create a behavioral health center and an expanded emergency department on our campus. We are in the home stretch of that project that was designed and established pre-COVID. But I think the timing is essential, because I do believe that I've heard this described as sort of a three-phased public health crisis: the immediate public health with COVID, then the economic crisis, and then the behavioral health crisis that will follow. But certainly our behavioral health center at Duke Regional will bring together inpatient, outpatient, and emergency behavioral health care in one location as one hub, but then really working with the community and broadly reaching out in terms of making behavioral health care accessible throughout the community as well.
I think prior to COVID, I would have said, and I'm not sure that my answer is different today, but it changes a little bit because of COVID. I would have said it's our #1 health crisis. And there's no doubt that COVID has made the behavioral health issues and concerns even stronger through this period. It's a difficult time for people, and they're really struggling. Like Katie, across the Triangle, we have expanded the behavioral health zones in our emergency departments to better care for the patients there and get them in an environment that's not so crazy as emergency departments can be. The lights never go off in the emergency departments. The busyness never really ends. And to think that we're going to be treating people in a behavioral health crisis in that sort of environment it's not going to work. So we've all, I think, created these new zones that will better respect and take care of these patients, and really give them the kind of care they need and get them back into the community as soon as possible.
It almost sounds like you're saying there's a big transition going on in the emergency departments between the old way of, I'm not saying it's an old way, but they say, where are you hurting? How much do you hurt? The question is, where are you hurting? Maybe the question can also be, why are you hurting? And that goes to a behavioral issue. Chris, I want to send this question to you. This is kind of a clinical question from Deborah Carter from Cary. She wants to know, what are the top 3 comorbidities that are leading to COVID deaths?
That's an excellent question, and I'll be curious to hear what Steve and Katie think as well. One of the most significant comorbidities that we have seen is really obesity, and I think that speaks to when you get very, very sick with COVID, your lungs are kind of the organ that take the initial brunt, and folks who are living with obesity, when they aren't breathing themselves, it can be very, very hard to crank our machines high enough to be able to move their chest wall and get their lungs to expand and contract. And so in observations that we've sort of seen here locally, the #1 clinical comorbidity that I would say I'm most concerned about really is obesity. I'm wondering, there are certainly more, and so I'm wondering, Katie and Steve, kind of what y'all's experiences have been.
So I actually don't have anything to add clinically to that. Would definitely rely on your expertise in that area.
Steve?
Yeah, defer to the physician on the panel, but certainly obesity and diabetes have been at or close to the top of the list, and of course they're closely related.
Well, we not only rely on Chris because he's a physician, but he's also one of these Iron Men, that competes in these things. So he's like the most physically fit person on this panel, which, I'm jealous.
Well, Jim, I appreciate that. I think, given that opening, important to note that as I'm sure both Steve and Katie have, we have had folks who are more fit than me who get super sick with COVID. We have had folks with a lot of comorbidities who get well with COVID. And there's just so much that we still don't know about this virus in terms of why it seems to, in general, affect older folks with more comorbidities so severely and younger folks with less comorbidities less severely, and yet why even in those seemingly very low risk groups, we still have folks who get incredibly sick and some who die.
So overweight, elderly, what else would you?
Multiple comorbidities. So we've seen hypertension or high blood pressure, we've seen heart failure.
Okay.
You know, I think oftentimes COVID is that sort of one last thing that when folks are living with so many chronic illnesses, there's a term that we use as physicians, it's called their reserve, and that their body's using so much energy to overcome all of these other illnesses that this one last hit is kind of too much.
William Merkel, and William did not, or I don't have any information on where William is from, but William Merkel asked this question. Do you feel that access and connectivity is a challenge to the success of telehealth, telemedicine? And if so, how do you overcome that challenge? You know, coincidentally, a lot of the school systems have complained about in going on to online learning, there was not enough accessibility. How much of a factor is this? Katie or Steve, you want to start on this?
So I think, you know, we've seen a significant uptick in, and we saw it pretty immediately at Duke in terms of our telemedicine and telehealth visits. You know, we went from a few hundred visits a month to, you know, well over 1,000 a day in a period of about 2 weeks back in March. And some of that has tapered off a little bit, but we still are seeing significant volume in telehealth. Is there concern over that connectivity? Certainly, especially again, as we think about potential for inequities, certainly want to make sure that we're able to reach everyone. I will tell you that a lot of the telehealth visits that we're doing are not video visits, they're actually phone visits. And so those are more accessible, even for someone who may not have the data available to be able to do a video visit. They can do a phone visit.
So Steve, are you worried that there's the accessibility, the connectivity is a barrier or not?
Well, my answer would be very similar to Katie's, which is we've ramped up very quickly in the number of virtual visits that we've done. Many of those have been video, but a large number, to her point, were also done over the phone. But there's no question that, you know, broad scale availability of broadband or high-speed internet is going to be an important part of the healthcare system going forward, and that has really been emphasized by this sharp increase in virtual visits as a result of COVID. And we're going to need you know, stronger backbone in terms of broadband across the state and the nation.
Chris?
That's well said. You know, I think it's device accessibility, and at least in the short term, some of that has been solved for with payers allowing you to conduct a telemedicine visit over virtually any platform right now, even FaceTime. But to Steve's point, I came to the Triangle from the western part of the state, and there were broad areas in the mountains where there was no cell coverage at all. And it's really difficult to be able to have any kind of connectivity there. And so to your earlier comments around disparities, I think access to both the device and the data is really something we need to focus on. And I think our state and federal government partners as well.
Okay, this next question comes from Adam Tomciello from Raleigh, and I don't want the three of you to attack me in any way for asking this question. Adam says that he's heard that the high cost of healthcare is driven mainly by hospitals and providers, and he wants to know, how do you fix that?
That's a really good question, and it's something that we're focused on. You know, I think we want to make sure that we're providing the highest quality care, but also keeping in mind the importance of cost, and doing that at a reasonable cost. We look at how do we reduce variation in care, because that's where there's a lot of cost is embedded within variation in care. And so we're very focused on how do we reduce that variation. We're very focused on preventative care and certainly making sure that we're focused on case management or care management, if you will. So making sure that we connect our patients and make sure that we get the right care to the right patient at the right time. And through that work, through our accountable care organization and the work that we've done early on in that, we have been able to see results in terms of significant savings to the system, the overall healthcare system.
Guys?
Chris, you want me to go? I think Katie really answered it well. There are many components to why healthcare is so expensive in the United States. Hospitals, yes, they're a component, but there are many, many other components. Pharmaceuticals are a big component, but lifestyle is also a big component. And I think what we're seeing is a really positive shift in the way health plans are structured, and it's much more towards a value and wellness type concept. And in doing so, what it's doing is making the providers more accountable for the outcomes. And that's been a really positive step forward. And I, give a lot of credit to Blue Cross for really pushing this agenda across the state, because it has really changed in many ways, how we're approaching health and focusing us more on prevention and wellness.
Chris, I'm reminded of the old story of the little kid who's trying to get permission to do something. Then the dad says, check with your mom, and the mom says, check with your dad. And I can tell you, as a journalist who's been doing these kind of ththings for 50 years, I've had in private conversations, insurance executives say, oh, the hospital's the one driving up the cost. I've had doctors say, well, it's the insurance company. And I've had the hospital say it's both. And it's kind of frustrating for patients. It goes back to the question that this gentleman had, how do we fix it?
Yeah, Jim, I think I wish we had 3 hours to talk about that, in part because the nature of our health insurance system in this country is so unique. In no other insurance model would you, if I think about auto insurance as kind of an example, but we don't pay auto insurance to fill our car up with gas and get its preventative care. We don't pay auto insurance for discounts on XYZ and to access these kinds of networks. And so the notion of kind of the healthcare coverage and reimbursement model in this nation has sprung from decades worth of history in the 1940s and the 50s, but we are where we are, right? And there are cost opportunities all over the place. We know the administrative costs in our system are astronomically higher than elsewhere. And I think Steve spoke to kind of some of the barriers put in place from the various aspects of the system. We know that driving to value and value for patients, families, and our neighbors is where we need to go. I'm really proud of the work we've done in ACOs. WakeMed has had one of the most successful ACOs in the country in terms of driving that value. And to me, as long as we're progressing down that pathway in terms of reducing overall cost and improving clinical outcomes, then we're bending the curve to the good.
Henry Grady submitted this question. What are you doing to prepare for a second wave of COVID cases? And how do you plan to care for the physical and emotional needs of your frontline workers? Katie or Steve, you want to start with this?
Sure, I'm happy to start on this one. We go into this much more prepared than when this started. We've learned so much in the way to care for patients. I probably speak for the others and say our supply of PPE is much better. We've learned how to conserve it. And so we've really learned a lot through this. So I think we're much better prepared for second wave. The ventilators and things like that, which actually we're using a lot less. Anyway, we have sufficient numbers of those. So the big thing really does come down to how are we caring for our healthcare workers? And I mentioned it earlier, our Department of Psychiatry has been very focused on this. They have I think it's a helpline for heroes and some apps and things where we are connecting people with resources to get them the help that they need. But it has gone on for so long now. And as I mentioned in my earlier answer to the question, the toll it's taking on our healthcare workers is enormous. And so we're surrounding them with the best kind of resources we can. And also the comment to what can the business community do earlier is, we need another round of support. And so anything they can do to, whether it's pizzas or whatever, and I don't mean to solicit for gifts and things for healthcare workers, but that really helped them in the early phases of this, get through this. And so we've got to make sure that as organizations, we're providing that kind of support, as well as the behavioral and emotional support that they need.
Katie?
Yeah, I would say this is the one thing that most keeps me up at night is concern over the resilience for our team, because they are heroes, and they have done an absolutely extraordinary job over the last 8 months. But they're tired, and yet they still come in with a smile on their face every morning or every evening, depending on which shift they work, and come prepared to provide the very best quality care to our patients, and to every patient as an individual. And that's remarkable to me. But I think we need to continue to support them. So we're certainly doing that with things like, our psychiatry department has also been really instrumental in helping us. We have a personal assistance service. So we're trying to wrap around all of these services. I will tell you that early on, that support from the business community was unbelievable. And it doesn't have to be, because I know our businesses are hurting too. I recognize that. But it doesn't have to be food or giveaways. It can be the simple sign that they've, early on, it was signs out in front of our hospital just talking about, heroes work here. And those types of just reinforcement that, we as a community are thankful to you and care about you, I can tell you means so much to the team. They really do.
Chris, I don't think the message is lost on some of us that now know that you are in these Ironman competitions. It's all about endurance. And that leads me to think back to your time in med school, where you're almost taught to endure. And yet you and the nurses and all the folks have a breaking point. So wrap it up for me.
Yeah, Jim, that breaking point is different for all different kinds of people. My wife trained as an oncology nurse, and for her cup was refilled by speaking with elderly folks and hearing their stories, and she could get through that and personally be fulfilled. For me, I couldn't handle that. My cup was refilled by taking care of babies, and I still get to see babies in our NICU follow-up clinic, and it looks different now than it did before, and it'll look different in the future than it does now. When we talk to our ICU nurses, our ED nurses, some of them choose that profession because they thrive on the intensity. And we offer things, can we rotate you through different units? How do we make sure you're getting time? The response sometimes has been no. I'm now in this mode, and this is where I want to be. And so I think in part it's knowing where you're called to serve and what refills your cup. And then as the employer or the partner for independent medical staff, us making sure we're doing everything we possibly can to support their work at the bedside and taking away all of the barriers that live between them and spending time with their patients.
I want the final question to be a personal one and give each of you 30 seconds to respond to this. Who or what led you to a career in healthcare? And Steve, why don't we start with you?
Great. 30 seconds. Okay. Well, I grew up in West Virginia, and I've said this, I've been asked this question a lot. And West Virginia, the economy really struggled, and there were really two big industries. One was there's of course the coal industry, but in Charleston that wasn't big, but there was the chemical industry and the healthcare industry. And those were my two sort of touch points with what careers and things could look like. And but what I really identify with about healthcare is that it's got incredible complexity, and I like to try to solve complex problems, but it's also got a mission that I very much identify with. So at the end, when you've solved this complex problem, of course, that's always rewarding, but when it involves a patient or a better outcome for a patient or for families, that's far more rewarding than than making more widgets. And that's what really pulled me into healthcare.
Katie, who or what led you to a career in healthcare?
I actually sort of fell into healthcare. This was not my undergrad degree, as I told you earlier, was journalism. So this is, I have a really sort of non-traditional path to where I am. But I fell into healthcare when I started at Duke Children's Hospital as the public relations manager about 24 years ago, and have never looked back. And for me, it is about purpose. It's about mission. It's about people helping people, and I think it's just and there are so many different opportunities that within healthcare. It's a great field. So I love being here.
Chris, did you have a father, uncle, mother, aunt who was a physician or a teacher, or what was your story?
I didn't. My mother's a nurse, but I'm the first physician, and it's really about service. I think Katie hit it on its head that for me, your purpose is instantly clarified when you're at the head of a bed with a baby who needs to be intubated, and you and the team that you're leading is going to save that baby's life. And that kind of service mentality, it really, for me, it is an area that I could contribute. And recognizing that these days I sit in a slightly different chair, for us, our purpose as a health system is to serve our community. And I think throughout this pandemic, it's given us a chance to really step up and do that. And so I have been thankful every day that I chose a path in healthcare, because it's allowed me to be here right now.
Well, I want to thank all three of you for doing this. Katie, of course, is president of Duke Regional Hospital. Chris, chief medical officer for WakeMed Health and Hospital. Steve, president, UNC Health and Triangle Region. Great answers, and thanks for taking time to do this. And I'd also like to thank all of the folks in the audience, the people who registered. If your question was not addressed, please send us an email to communications@ncha.org. We hope you do that. Again, today's town hall has been recorded. It'll be available for viewing or listening at www.nchealthcare.org. So please share that with your community. So again, thank everybody for doing this. I want to remind everybody to wear your mask, as our guest has told you. Wear your mask and practice social distancing, and wash your hands, and stay well and stay safe. So to everybody, thanks to NCHA. Thanks a lot.
Thank you all.
Thank you, Jim.
Thank you.
Good job, guys. Thanks, Steve.
Thank you. Take care.
Thank you, Jim. Take care.
Thanks,
See you, Chris. See you, Katie.
James.